It's my pleasure to welcome you to Grand Rounds today and introduce to you Dr. David Zbara, who's one of our main campus colleagues from the Department of Psychology, and this afternoon's speaker. Dr. Zbara is an assistant professor of the U of A Department of Psychology in the clinical area and also serves as interim director of their clinical training program. Dr. Zbara received his PhD in clinical psychology from the University of Virginia, and he has since been active in research, participating in a number of NIH-sponsored studies that include aspects of divorce, depression, and behavioral dysregulation. Divorce in the midlife, mechanisms of biopsychosocial adaptation over time, case simulation methods for teaching empirically validated behavioral treatments, and meaning-making in the context of divorce, links with emotion regulation. Additional research interests include social connectedness and health, psychopathology following social disruptions, close relationship, chronic pain association, as well as divorce and adult adjustment, including divorce-related grief, autonomic psychophysiology and facial electromyography, and social neuroscience and multi-level theory. I have known Dave through his work in some of these aspects of psychophysiology and projects related to divorce and risk of psychopathology in association with that, and we have been honored of being collaborating with him in a proposal to study also genetic links to the vulnerability of depressive disorders in the context of divorce. Dr. Zbara is recipient of a number of honors and awards from professional psychological organizations, also has a number of peer-reviewed publications on a variety of topics that primarily cover his research interest. Additionally, he has lectured widely, both nationally and internationally, on a variety of social issues, transitions, and losses. This afternoon, Dr. Zbara will discuss social relationships and health, research, overview, and practical application. Dr. Zbara has nothing to disclose also, and please help me welcome Dr. Zbara.
Thank you. All right, thank you, Francisco. That was very nice. Let me get started today by just saying it's a pleasure to be here, and I'm going to talk about some topics that may be a little bit different for this audience, and I hope that's at least why some of you came. I'm spinning off from talking about psychopathology, and I'm spinning off from talking about DSM and Axis 1 disorders and moving away to something else, which is my area of expertise and research on social relationships and broad-based health outcomes. I could switch this around to talk almost entirely about mental health, but today I'm going to give you an overview of some of the physical health outcomes that I think are relevant and also very interesting. So if this is not your main area or your main area of interest or want, then hope you'll enjoy the ride a little bit and learn some. Okay. Interpersonal psychiatry is actually a field that I'm very interested in, and there's a long and rich tradition of thinking about social relationships in the field of psychiatry. And we begin with one of the first defectors of Freud, and this is entirely brief and incomplete history, but Karen Horney started with the notion that neuroses are rooted in early parent-child relationships, and she spurred a theory of neurotic needs that is very meaningful, and she talked about moving toward, against, or away from people, and this is basically a typology of the development of different neuroses. I'm not a psychoanalyst by any means, and the credence that you would give these various theories could be debated at length, but I just want to sort of put us in a historical context to get started. Perhaps one of the best theorists out there is Harry Stack Sullivan, at least in terms of interpersonal thinking in psychiatry. His 53 book, my postdoc working with us has it on our desk right now. I saw it when I was leaving the office yesterday. It's a classic little textbook, and he was really the first to put forth this idea that mental illness is embedded in the interactional, not necessarily just the intrapsychic. And this is a very powerful idea. Stack Sullivan was the first person to put forth this idea that loneliness is the most painful of human experiences, And if you're not familiar with these notions of parataxic distortions and integrations, they're also incredibly meaningful from a clinical perspective. Melanie Klein, in thinking about object relations theory, put forth, I think, one of the most powerful ideas that are out there for working with couples, and that's the notion of projective identification. So these are very powerful and rich ideas. And of course, we will end with John Bowlby, who was not only a psychiatrist, but an ethologist and a primatologist. But he spurred attachment theory, which is a normative account of the making and breaking of relationships, and I think very important for our thinking about the development of health problems. Major extensions that are of relevance to us are the topics of individual differences, how people represent relationships in their mind, and the notion of how people regulate their emotions and the concept of felt security. So variability in the regulation of emotion. Okay, so that's all for interpersonal psychiatry. That's my very brief introduction. Let me talk about what I want to do today. This talk is in 3 parts, sort of like This American Life with Ira Glass. Okay, part 1 is going to be, I'm going to review findings from a field of social epidemiology. Some of you have heard me talk recently, and this is a particular area that I'm becoming very keen on. I'm going to talk about some macro-level studies that are pointing us in the direction of the very large effect sizes associated with social relationships and broad-based health. So I'm going to do this strictly by way of documenting effects of interest. And then part 2, I'll connect this literature to some of my own work on social psychophysiology, and I'll talk about how we're trying to investigate some of the mechanisms that are interesting here. A lot of this is very basic research, and we could call it social neuroscience or standard clinical psychology or social psychology, but in the end I'll attempt to draw some practice implications and basically ask the question, with this knowledge that I've talked about today, what should we do differently now in terms of how we are treating our patients? I have very little to say about pharmacology and a good amount to say about psychotherapy and therapeutic implications. Okay, so part 1, social epidemiology. I've been doing a lot of work in this area now, and some actually in medical epidemiology, and it's absolutely fascinating. The difference between, you probably well know this, but let me just sort of spell it out. The difference between this area and my home discipline of psychology is that in social and medical epidemiology, the measurement is terrible. Very poor measurement of constructs of interest. Very, very large samples. Okay, so you're trading numbers of people for quality of measurement. Now, blood pressure, you measure blood pressure, is not much measurement variability when you have trained assistants. But in my discipline, smaller numbers of people, very high quality measurement. These 2 things go hand in hand to present us with an interesting picture. Okay, so this is the beginning. It's not really the beginning. I don't know when the beginning is, right? But for our purposes, it's good enough. This was a paper published in Science in 1988. And my useless but interesting fact about this paper, it's been cited twice a week for the past 20 years. So this is a major and powerful paper in the field of social epidemiology. And what we see here is that this is a sort of quasi-meta-analysis of the link between social integration, where people are just rating the quantity of their interpersonal relationships, and age-adjusted mortality. And we basically see that the higher the social integration across a series of very large population studies, the lower the age-adjusted mortality. So it's the first real paper to spawn this movement, and it's very interesting. The problem with this is that a lot of these studies essentially ask people, or essentially ask their participants, how many people do you feel close with? What is the number of people in your social network? On a daily basis, who do you see and have contact with? From a mechanism perspective, these are not the kinds of things that we think actually influence health, so we need to get a little more specific. This first part is just a tour of the different areas, really. This is not meant to be read in any definitive fashion, but I'm trying to show you at least the breadth and scope of this research. This is a paper published in The Lancet in 2007, not a quantitative review, but a really synthetic qualitative review demonstrating that bereavement is associated with excess risk for mortality. I'll get more specific about divorce effects a little later on. But there's an interesting fact about bereavement. This is particularly in the early weeks and months after losing a partner. There are some really interesting effects to show that if your partner dies and you survive for up to a year, your actual life expectancy is longer than other people in the sample, in standard samples. So the effect being some sort of stealing quality of making it through a critical period of risk or vulnerability. Okay, this is from a very large study of, I'll show you, I realize the text is very small. I'm only including this to show you what I think is interesting here. So this is a 9-year follow-up study of men who were divorced, and what I just want to show you here are the relative risk indices associated with all-cause mortality. These are published in the Archives of Internal Medicine, which I understand is a decent journal. So basically, you can go down the list. There are effects that are quite large here, including accidents and suicide and those kinds of things. Okay, this is a meta-analysis we're doing in my laboratory, and I only am proving that we're doing it by inserting this Excel spreadsheet here. I'm not trying to show you any numbers, but this is really what's going on for us, and I'll tell you what we're doing. This is a study of this is a study of all the large population-based studies that are out there that are prospective investigations of the divorce health effect. These are 18 risk hazards. These are proportional risks from Cox risk hazard models. Over 700,000 people studied in 13 different countries, more than 11,000 adults. The unweighted risk hazard is approximately 1.49. So at each follow-up period, this is unweighted. At each follow-up period, someone who's divorced relative to someone who's married has 1.4 times the chance of being dead. Okay, and I'll say a little bit more about that. But we really, really need to put this in context, and this is an important question for all of medical epidemiology. So you may be scoffing at this and saying, oh, you know, this depends on a variety of things. I want to put this in context for you and show you that it is actually very meaningful. So you can treat this risk hazard as a relative risk, which is a little bit problematic, and do some transformations. And you'll bring this into something that meta-analysts use quite a lot, which is called a binomial effect size. And this says, okay, let's suppose there are just 100 people in a sample, and we have those who are alive and who are dead. It's a 2-by-2, and those who are divorced and are married. Our meta-analysis thus far is suggesting that the breakdown looks something like this, with our phi coefficient of 0.19. If you're interpreting correlations, you may say this is sort of a small correlation. I don't know how large that effect is. For every 100 people, if the difference is really 10 deaths. But this is the kicker here. If we take a look at something that is widely considered one of the most important medical findings of the last, I don't know, it's debatable, top 10 important medical findings in the last 25 years. This comes from the Physicians' Health Study, which is a study of 22,000 men, and they're given aspirin and placebo to prevent MI. Does anyone know right away the outcome of this study? The trial was canceled because the effect was so powerful. Look at this R-phi relative to this R-phi, and this relative risk compared to this relative risk. We're talking about, these are the differences in the binomial effect size. We're talking about fairly large effects here. Now, I'm not silly enough to get up here and start spewing about the importance of social relationships relative to the mechanisms. We know the mechanisms operating, or you guys know, I don't know anything really about the medicine part, but we know the mechanisms much better on this side than this side. So here a smaller effect is more meaningful because biological pathways are laid out. But just comparatively, we have a relatively large effect. That's important to think about here. However, for those of you who are sort of thinking about divorce and your own death and those kinds of things, I want to say that the case is really not quite clear. This is a paper we published in January of this year, and these are some survival analyses of, this is from the Charleston Heart Study. So a study about 3,000 people, and this is looking at the effect of participants who divorced and then never remarried and following them over time. the sort of first take-home finding is that there's a big difference between experiencing a divorce and never remarrying, and in terms of long-term survival. So about 20 years, this is a 40-year follow-up study, about 20 years after the study was initiated, about 60% of the people who didn't remarry were dead, whereas only 60% were alive, whereas 80% of those who didn't divorce were alive. If you switch how marital status is being classified and say, if you're ever separated and you remarry, what does the survival curve look like? They basically map onto each other perfectly. So how the relationships we're talking about and how they're defined make a very big difference in our thinking in terms of operationalizing these effects. Okay, on to different topics. There's widespread epidemiological interest in the study of loneliness and social isolation, including social exclusion. Most of the mechanistic studies that have been interested in trying to pin down what it is about loneliness that influences our health have failed. And we don't see, I'll show you an effect that is an autonomic nervous system effect, but we don't see large neuroendocrine effects. We don't see large differences in health behaviors effects. One of the things we do see a lot of, and this is a well-known paper, it's called Lonely Days Invade the Night, are sleep quality effects. So, and many people are, I think everyone is aware of the salubrious nature of sleep, and we see this in terms of sleep efficiency, so the amount of time you're in bed and you're actually sleeping, and this is replicated in two different samples. And we also see wake time after onset, so the amount of time people are asleep at night. So these are differences that people start thinking about in terms of the restorative nature of sleep and the way it's really influencing health. There are other effects that are interesting in terms of loneliness. Loneliness, and this is a paper that sort of violates a variety of regression analysis premises by putting everything you can possibly think of into a regression and then looking at the final significant predictor. But here we see large differences in people who are extremely high in loneliness and extremely low in loneliness in terms of resting systolic blood pressure. And this is something, I'll talk a little bit about blood pressure with respect to our own work as we go on. Okay, I'll finish this part one with a simple tour of marital quality. And this is from some of my colleagues in the psychology department. Very interesting stuff. So here we're looking at marital quality in cardiac, let's see, this is congestive heart failure sample with Michael Rohrbaugh and Bader Shoham. So we have a large congestive heart failure sample, and basically they're following them from the time they come out of rehab until until 96 months later, and saying what proportion of people are alive and how does the death rate vary as a function of marital quality. So we see right away there's a very large main effect for marital quality for both men and for women. It looks like for men, after 96 months, people in low and high quality marriages have died at the same rate. For women in the high quality marriage, there's really a buffer from the early mortality. So this is an interesting effect, and it fits in context with something that at least one aphorism you should be aware of in this literature, and that marital quality is alleged to matter more for women, and there are effects documenting this in a variety of ways. Marital status is alleged to matter more for men. So that is, for men, if you're in a crappy marriage or a good marriage, well, someone's still taking care of you. So men really suffer consequences when relationships dissolve. For women, women are much more sensitive for the quality of relationships. And this is not me just being a blowhard, it's empirically documented. Okay, so if we think more systemically, there's a very interesting effect nested here, and this is spouse confidence and death in this same congestive heart failure sample. So basically, they went back and they looked at spouses' confidence in their partner's ability to follow the cardiac rehab regimen. And I think this is a very interesting construct. They looked at the spouse and they looked at the patient, and this is the way they defined it. Patient versus spouse efficacy. And the really interesting finding here is that for women patients, for female patients, when their husbands have greater self-efficacy or greater partner efficacy, that is when their husbands are thinking that they can actually do it and they can actually follow the regimen, there are significant differences in mortality. So this group differs from all of these others. So there's something about having a spouse believe in you more than you believe in yourself. I mean, that's an interesting concept that matters. Now, of course, you may also, and very well should be screaming, there are all kinds of third variables involved in these analyses. If your partner believes in you more than you believe in yourself, it also speaks to good marital quality, also speaks to good health behaviors. These are just documenting the effects. They're not interrogating the mechanisms here, but this is interesting to think about. We've been involved in some new work that is under review right now, looking at C-reactive protein and marital status. And the funny thing about this is I was talking to my friend who's an emergency medicine physician, and he's saying everyone's looking at CRP now, and it seems to be particularly hot topic. But we got into it because there are terrific new biomarker assays that can derive CRP levels from blood spot samples, and thus they can be collected in very large samples. And this is a sample of over 3,000 aging adults around the U.S., so it's a representative population sample. And I'm going to show you the basic take-home figure here, and then I'll show you some of the findings. But first, big picture. So C-reactive protein, many of you are well aware, is an acute phase reactant that basically is a downstream indicator of systemic inflammation. It's highest when there is actually acute inflammation, but normal levels of variation in the population have been shown in over 50 prospective studies to be linked with the development of cardiovascular disease. So it's an important biomarker of interest. What we're looking at is the absolute risk reduction, okay, the absolute risk reduction for being classified in a high CRP grouping. Okay, so how much does the variable play a role in reducing your risk of being classified? The opposite of this is the number needed to treat, and that's a very common statistic in treatment studies of medical epidemiology. But here we have the absolute risk reduction, and what we see is that the absolute risk reduction for being a married man, so this is the effect of interest, is largely just for men. Married men are uniquely protected from clinically meaningful elevations in CRP relative to married women, divorced men, and divorced women. This is a sample of over 3,000 people. The magnitude of this effect is roughly equivalent to having normal BMI about 25 or below. Problem is not, there's problems at the lower end of that, I realize, but being a non-smoker and being normotensive. So this is an interesting effect, and apparently my other slides, I cut it out, it was too many numbers, okay? So what can I say by way of sort of a synthesis and summary of part one? We talked about a variety of health indices, and I tried to convince you at least, and I moved through it relatively quickly, but I tried to convince you that there is an important association with health, and we need to start thinking carefully about some of the mechanisms of action. And I think for anyone who's practicing psychiatrist, family physician, or clinical psychologist, that there's a lot of relevance in this data, and thinking about how it plays out for individuals is probably the biggest question there is. From a mechanism perspective, we think about a variety of things. One of them is a cardiovascular reactivity pathway, right? So being in a high-quality relationship means you're fighting less with your spouse. You're probably feeling less hostile when you're going around day to day. There's data to support this. And these effects are having long-term implications for the wear and tear of your cardiovascular system. I don't know how plausible that is. There's some data that speaks to it. I'll show you some from our lab. I think probably we're talking more about a health behavior pathways. Your high-quality relationships prevent you from smoking. They help you get better exercise. They prevent you from eating too much red meat, et cetera, et cetera. So we're really trying to understand this now, and I think it's very important. Okay, so part two. What I'm going to do in this part is talk about a lot of our lab-based research. I'm going to talk about, in particular, about a few studies that I think are of interest to you, and hopefully, actually just 3. And I'm hoping that, we have a lot going on in my lab, I'm hoping that these 3 can just sort of stick in your head. You won't need to remember the details, but if you remember something about them, I think that will be helpful, and I hope that it would pique your interest in pursuing this line of work, or at least thinking about it on your own part. Okay, perhaps you have seen our riveting ad in the Tucson Weekly. This is participants' need for a marital transition study. We have 2 grants that are active right now, one from the National Institute of Mental Health about risk for the onset of a clinically significant depressive disorder following the marital separation, which is basically beginning of a divorce experience, and another one which is looking at indicators of autonomic nervous system functioning, both as relevant for long-term health outcomes and largely as indicators of emotional responding, so largely not diffuse arousal, those kinds of things. We're tracking people over time and trying to understand of how people make sense of this difficult experience and go from being very disorganized and dysregulated back to feeling relatively calm, and that they have a good sense of how they're handling different experiences in their life. So we have a pretty large sample now of divorced adults, and it's about 130 or so. We're bringing people in all the time and running them through our paradigm. And our paradigm consists of a couple of things, one of which I want to talk about here today. So we bring them in and we hook them up with a variety of autonomic measures. I'll talk about 2 today. One is just systolic blood pressure, looking at systolic blood pressure reactivity and resting levels. And then the other one is heart rate variability as indexed by respiratory sinus arrhythmia. And I'll talk a little bit about how psychologists use it, which may be different than how physicians study it. Okay, so we hook them up with our equipment, and then we let them sit quietly and they watch pretty peaceful nature video. Then they do some other things like think about relatively mundane events in their lab, just to look at sort of the physiological deployment when they're thinking about things. And then we ask them to reflect on a series of questions while they're measuring their while we're measuring their reactivity. And these are the divorce-specific mental activation task prompts. Okay, I'm not going to run through all of them, but you can read it. Each one lasts a minute, and they sit there, and we really get them to try to think about what happened in their relationship. We measure some impedance cardiography, so we don't ask them to talk because it really messes up the impedance signal. So what these people are actually thinking about, I have no idea. But you know, that may be part of the problem here. But we're at least they tell us they're thinking about their separation, and they tell us that they're that this feels, at least approximates how it is for them in their everyday life. So it begins with thinking about how you and your former partner met. Then it goes through a series of questions prompting them to think about how they arrived at the end of the relationship, what's happened since they've broken up, and basically what's been the hardest part. Our design of this is really to see, is based in attachment theory. Attachment theory has a very fundamental core idea, is that if you want to see the attachment system in activation, you need to probe it, and you need to push it pretty hard. So if you think of the classic attachment system paradigm with young children, it's called the strange situation, and we bring mother or caregiver, an infant into the room, and then mother goes out and a stranger comes in, and it's very upsetting for a 1-year-old or a 10-month-old or a 14-month-old, right? So we're developing similar paradigms for stressing attachment system in adults for people who are struggling with their divorce and trying to come to terms with it. We're expecting larger cardiovascular responses, really understanding what happens at the level of physiology when people are thinking about their separation. Okay, this is a paper that we have impressed in the journal Psychosomatic Medicine. And basically, it's our first cut from this, just focused on systolic blood pressure. Here we have people followed over, this is systolic and diastolic blood pressure. So we see, you know, our baseline is in the 130s, and then we get some bumps. When we ask people to think about things, we get a pretty linear slope in the DMAT, and then a little bit of a recovery with some bump going on. This is just to show you that we did actually measure blood pressure, so nothing of interest there. Okay, there are two effects here that I'll talk about that I think are interesting, and the important thing is that they're independent. So we ask people to sort of tell us about their experience on a variety of questionnaires before they come into the lab, And this is the first real finding. The IES scale is the impact of events scale. And basically it's subclinical PTSD-like symptoms. So how much, and this is an emotional intrusion hyperarousal scale. So how much do people report that they feel very tense and anxious, on edge, keyed up, and how much do they report that they can't stop thinking about their separation or ex-partner, that they can't stop, they're having dreams about it, they're having overwhelming pangs about the experience. Okay, so now we're looking at men and women, and we break up the IES. Well, it's a continuous analysis, but for illustrative purpose, we break it up to people who are 1 standard deviation below the mean and 1 standard deviation above the mean. And this is the difference here in resting systolic blood pressure is significant statistically, but also substantial and meaningful. And we see that from the baseline, from the average, people who are 1 standard deviation above the mean, just 1 standard deviation above the mean, are getting about a 6.5 millimeter mercury bump in their resting blood pressure. This is accounting for things you would want to account for, what drugs they're on, how much smoking they're doing, when they last consumed caffeine, and a variety of health habits. Okay, so this is, we think, a very interesting finding. And the interesting thing about this is that, as I said, it's independent from the second finding. So this is just at baseline. And the second finding is this, and I'll walk you through this. What happened was we asked people to rate their emotional experience while they were doing the DMAT. So right after DMAT, we said, what was that like? How hard was it for you? How emotionally difficult? How upsetting? And we have a score, task-rated emotional difficulty, TRED. Okay? We can look at men and women who are high and low on TRED, hence the 4 lines. This is during the first task, which is asking them to just think about something generic and mundane, and this is during the DMAT. So these are reactivity scores. Okay, important things of interest. For women, no difference. DMAT doesn't do anything. It doesn't even budge them, right? So they have their blood pressure, no real effect. For men who are high TRED, who rate the task as very difficult, I found this very emotionally upsetting, we see a substantial increase in their blood pressure from the mundane events to the DMAT task. For men who say it wasn't difficult, we see this, we see a significant lowering here. These two differences, starting points, these two differences are not statistically different. They just look different. Okay? So, and that has to do with the variability of the sample. I think this is a surprise effect. It wasn't as bad as I thought it might be. And this is really a holy crap effect that I can't believe I just had to do this, and it was very difficult for me. So in combination, this effect with this effect is putting men who are having, the men who are struggling most with their separation experience in really high-level blood pressure territory. So they'd be considered hypertensive, and this is the levels of blood pressure that any physician would consider needing treatment if they just walked in off the street. Now, there are a couple of caveats. First is I have no idea if these things persist outside the lab. I don't know what it's like when these people are sitting up at night thinking about these things. Do they experience blood pressure reactivity in this way? Who knows? I mean, this is a really important study, and we are launching an ambulatory blood pressure investigation. I mean, this is a really important question. It's not an important study. It's one of many studies. But this is an important question that we're trying to follow up on, because if it has no bearing to real life, then it's really not meaningful. The second point of interest here is that, I forgot. In any event, the first point seemed interesting enough. I was going to say something else. So, all right, move on. So that's study 1 here. Oh, I got it. The second point. Sorry, I'm spacing here. The second point is that there are really important differences in terms of whether this effect is derived at the level of cardiac functioning or changes in the vasculature. And so if we see, and we have the measurement, this is the impedance cardiography, to derive total peripheral resistance. And this is the construct that is going to be most interesting here. Because if it's just cardiac measures, I'm not particularly interested in it. If we see more vascular resistant changes, this is where we really see potential wear and tear at the level of the vasculature that may have long-term health implications. So that's the second point. I think that it really we have to know what's underpinning these effects at a deeper level of ANS functioning. Okay, so second finding, second set of analyses, different samples. So this is a smaller sample of about 30 adults who've recently separated. This was a pilot sample that landed us some of the larger grants. But we have some new data on this that's proving to be just as or more interesting. These are the slides that are fully cooked up right now. Okay, so RSA, as many of you know, respiratory sinus arrhythmia is a frequently used ANS and a frequently used measure of ANS and emotion regulatory ability. It basically reflects parasympathetic vagal influences on the heart. So the vagus nerve exhibits a tonic inhibitory influence on heart rate. So the vagus is slowing the heart, right? So we call this the vagal brake. And a lot of increases in heart rate are associated with the lifting of the vagal brake and just basically not surges of sympathetic influence, although there can, of course, be coactivation in a variety of levels. Okay, so many people use RSA as a measure of emotion regulatory functioning. So emotion, and this is more psychology babble here, but psychologists think of emotion as functioning across many, many different channels. And we understand self-report, we understand behavior, and there's also, of course, a physiological channel, and RSA proves to be a good measure. We can think of cross-task reactivity as a measure of self-regulatory capacity or effort. And so here's the effect I want to show you. I think it's the next slide. Okay, so this is our first 30 people in our divorce study, and we have them organized in terms of their ID. I'll tell you what the ID numbers mean in a minute. But basically, we're zooming in on RSA levels during the DMAT, and we're honing in on this. So this is, every dot here is one of the DMAT minutes, and every square is a new person. And we're looking at within-person variability in RSA over the course of a task. So how much are they bumping around as a function of how much time they say they spend thinking about their ex-partner? Up here, this is ordered in descending order. So number one is the person who says they spend 100% of their time, they're lying, every day thinking about their ex-partner and the marital separation. Down here is someone who says they spend no time thinking about them. The interesting thing of interest here is that if we start looking across these categories, across these people, we see larger variability during the task in RSA, bumping around than for people who are reporting low levels of mental preoccupation. So I can quantify this. It's easy to quantify. You actually just take the standard deviation. This is crude. You take the standard deviation across all of these measurements. So how much are they bouncing around from their average point? And you correlate that standard deviation with other things. In this particular effect, we show that high levels of within-person variability, as indexed by the standard deviation, during the DMAT are associated with all kinds of things that are indicative of poor outcomes of the divorce. Preoccupation, avoidance of any thoughts and feelings, Beck depression scores, and how much they're longing to be together with their ex-partner. This difference between rest and the DMAT gives some credence to our suggestion that if you want to see the effects of interest, you better stress the system. If you don't see the effects, they're not significant just at rest. You need to probe the system, interrogate the system, and then you see the effects. So you want to ask your patients what's going on and push them a little bit to see how they're regulating their emotions. But that's just sort of an off-the-cuff comment. This is more specific to divorce adjustment. Okay, so for us, we're now honing in on this idea of how are people regulating their emotions. RSA, heart rate variability, are in other studies associated with downstream health indicators that really matter overall. So this, I think, is noteworthy in this respect. Okay, last thing. Change the subject entirely and talk about romantic breakups in college. This is a large sample. Breakups are easy for us to get on the main campus. They sort of happen outside my door 3 times a day. And, you know, I actually started studying romantic breakups when I was a graduate student, and sort of always had this self-loathing that I really was not studying anything important. I was like, well, there are divorces and breakups are not that important. But there have been a series of papers that have come out that have suggested that first breakups in adolescence and early adulthood are the single greatest predictor, looking at everything including the kitchen sink, of first onset major depressive episodes. Now, I don't know genetic loadings relatively here, I guess it would interact with certain history, family history kinds of things, but you can account for all other kinds of family variables you want. Whether or not people have had a recent breakup is a significant and meaningful event in terms of predicting clinically significant psychopathology. So there is some interest in study in that respect. Otherwise, we can do a variety of things with it. Captured population, so to speak. This effect, I think, probably is one of the favorite things that I've ever been involved in, and it's the thing that I've had the most trouble getting published. I absolutely cannot publish it anywhere for a variety of reasons, but I think largely because, I don't know, I'm not even going to speculate. Okay, here we go. Basically what happened is this is an investigation of a personality or sub-personality characteristic that is consistently associated with poor adaptation to stressful events that involve relationships. And this is an individual difference in attachment style. So you can characterize people with respect to their mental representations of relationships. That is, how do all of us think about the nature of close relationships? And then you can look at how people vary in dimensions of that. And this is one particular dimension, which is called attachment anxiety. So we all vary in this dimension, and people who are high in attachment anxiety are primed to look for relevant themes in close relationships that are characterized by jealousy, distrust, avoidance, enmeshment, all of these kinds of things. People who are high in anxiety are hyper-aroused and hyper-vigilant to relationship-related themes. When relationships devolve or dissolve, people who are high in anxiety often engage in relentless pursuit behaviors to get a partner back, to speak with their friends, to talk with their family. They're hyper-focused on relationships, on the outcome of relationships. So we're looking at this in a variety of ways, and here's the basic association of interest. We bring people in the lab, and now we interview them. They're talking about their experience, and here's what's going on. We know their attachment anxiety, and we're measuring their heart rate reactivity. So this is the basic hypothesis of interest. People who are high in heart rate in anxiety demonstrate much larger heart rate reactivity in the lab. That's not interesting at all, but we can measure it, okay? So the interesting part is that we can fully account for this effect based on the words that they use. And this is what it looks like. Okay, so this is attachment anxiety. It's associated with significant heart rate reactivity during a breakup experience interview. This is a residualized change score. We account for their levels, their resting heart rate, and we account for a variety of other things. But then what happened was, because we were interviewing them, we had little minions recording the interview, they were aware of this, and then transcribing the interview. And we took the transcriptions of the interview and we submitted them to a text analysis program that is completely stupid. All it does is count the words people use and classifies them into certain categories. In this particular program, there are 79 different categories. And it turns out that some of them are associated with both attachment anxiety and heart rate reactivity. And we find a full mediation effect here through the use of first-person singular words. And these are basically words, me, myself, and I. And we interpret this as self-focused attention. When you interview people about their experience, and they are consistently focused on what has happened to them, what's wrong with them, what is wrong with their life and their experience, and what this person did to me, you see much greater increases in heart rate. And for anyone who's ever worked in any kind of clinical capacity for any measure of time, this is absolutely consistent with the way you see people working themselves up into a tizzy, or having difficulty calming themselves down, or being very dysregulated cognitively. Now, are the words people use truly causal in the heart rate reactivity? I'm sure the answer is no, and that this is a recursive link here, but there are a variety of things to suggest that these are important correlates, and I think that's of interest for us. Okay. So, does anyone have the time? I don't. Quarter two. Okay, so we arrive at part 3, and this is going to go from a quarter till until 10 till. It's going to be very quick. And this is some integration and practice implications, or what does this all mean for me? And I don't know who the me is that I'm talking to, but me, I'm just sort of thinking of someone who's involved in clinical practice right now, either psychiatry or psychology or some allied discipline. Okay, so let's start with a series of thought questions. Where should we begin? What is the social context in which our patients live? What is the network size, and what is the quality of these relationships? Depending on your clinical orientation or your sort of primary practice orientation, you may or may not think a lot about this. Now, everyone should be aware of it. I think that's the gist of what I'm getting at. But I really want you to ask the question of yourself. You sort of run down your most active patient list. Who are they living with? What are their relationships like? Who do they go to for sustenance and nurturance? And what are all these things that are happening in their life? I think a lot of this literature that I've reviewed and the studies that I've talked about are really important in sort of channeling us to think about these issues and to get us to understand what's going on in people's lives. And I mean this explicitly and behaviorally. I had a great supervisor who used to tell the story of Salvador Minuchin would always say, the famous family therapist, Salvador Minuchin would always say, if there is a fight in the home, your job as the clinician is to understand exactly what room people went to, who did what, where did they go, so well that you can sit down and draw a map of the house. And I thought that was always very elegant, because you could come up with a picture of the kind of behaviors that were in just these relationships that often get talked about but not really assessed in any meaningful way. Now, this second part is, what do our patients think about their relationship, or these are their relationships? This is what psychologists would refer to primarily as social cognition. It's people thinking about people. And the divorce study that I talked about in particular, our data, it's inherently individual, but a totally dyadic process. So what do people think about? And the basis of our study, at least, was to understand, and I don't mean this tongue-in-cheek in any respect, was what happens to people when they sit up at night thinking about what's happened in their life and their relationships. What are they thinking about? What processes are unfolding in their body? How are they getting themselves tangled up into a giant ball of yarn? And this has both diagnostic implications, but it also has treatment implications and understanding how to best approach the problems that we're looking at. In what ways are we working to alter or improve these relationships? So I think that even in a situation where you're dealing with a 15-minute medical management consultation or a medication management consultation, there are important issues around this. Who are you talking to? What's happening? What's your life like on a daily basis? The most important people in our lives make a very, very large difference in medication adherence. And I think this is absolutely fundamental. And I would actually go so far to say that I think it's one of medicine's dirty little secrets. Basically, that there is so much about medical practice that has to do with interpersonal relationships that we really need to invest our time in understanding this. I'll give you a very quick example. Was that I worked in a family medicine practice for a year during graduate school, and the family medicine practice had a very unique treatment philosophy, is that every family medicine encounter involved one psychologist and one family medicine physician. Now, sometimes I just stood there when physicians cleaned earwax out of people, all gunked up, and I really had nothing to contribute, right? So that was, but there were other times when I did, and I would be very involved, both with the patients and with the physicians. And I would see over and over again, physicians would write scripts and say, take this. Why are you doing that? Why do you continue to smoke? And sort of blaming and beating on patients. Now, there are a lot of good doctors, and maybe those are just bad eggs and bad seeds. But the issue of when you hand a script to someone, thinking about adherence and who in their life is going to help them adhere to the regimen or block them from adhering to the regimen has important implications for their health. And I think we could sort of retool this entire talk to think about that. What are the connection between relational disturbances and upheavals and various health behaviors? There are many, many people who their primary mode of coping and dealing with difficult experiences in their relationships is to do something unhealthy. And that is just sort of, I had to smoke, or I had to drink, or I just went out and forgot about everything, or slammed my hand into the mic. But you get the idea here, that they're thinking about these things is very critical for understanding these broad-based associations that I talked about earlier. Okay, this last slide is sort of my quick approach at thinking comparatively, and out of the interest of time, I'm just going to sort of say we can think comparatively and really close. I mean, there are all kinds of different therapeutic treatment interventions that have at their core relational foci, right? But other ones that we may not think about also can be imbued this way, and we can start thinking about the role of relationships from a variety of different treatment applications. So I left my last slide at home, which was a thank you slide, but you know, I hope this has been enough and of interest. So thank you very much. Are there questions, or do I just leave?
Are there questions? Regarding the heart rate variability and the basal activity,
Yes.
Is anybody studying, I'm wondering if it's possible to study nitrous oxide at the mouth, whether, because nitrous oxide is vasoactive.
Right.
It comes out, I mean, I don't know if that might be a way to get to it. Have you heard of that? Or
I have not heard. Karen, have you heard of that? No. I don't know. I mean, it would be very interesting. The notion of other sort of less invasive means of studying these processes would be very interesting, but I haven't heard of that at all. Yeah. Anything else? All right, thank you.
Thank you very much, David.
Yeah.